Click whatever. Sorry about that. Click whatever calendar you are using and then click add, and all the future TSAC meeting dates and times should automatically show up. Does anybody have any questions on how to get the TSAC meetings on your calendar for the rest of the year that I can help with? Okay. So if you guys have any concerns about Zoom, please feel free to add them to the chat, or at the end, I'm going to provide my email. Feel free to send me an email with any of your questions, and I'll work on those questions with the internal team that manages the Zoom. So next slide. Okay, so as a department, we are currently developing a streamlined escalation process for all the transition related issues. I believe Nora has previously shared this with you, but I wanted to send a reminder out to everyone that moving forward, please email the designated inbox provided on this slide for any concerns related to transition escalations. This will help us prepare for implementing the new process in the coming months. We will share more information about this process via email and during our upcoming TSAC meetings as soon as it becomes available. So if you have a transition escalation, rather than emailing Nora, please use this email inbox to provide any information that you need assistance with moving forward. And our next slide will go to our first presenter, which will be Sarah, and she'll be providing you with information regarding a new project called Rapid Reintegration. Go ahead, Sarah.
Thank you. Everyone, I'm Sarah Geisler, and I'm on the InReach team. I'm just going to present a broad overview of what rapid reintegration is, also what the process will look like, and then I'll open it up for any questions or ideas or anything at the end. So if you can go to the next slide. So rapid reintegration is the process that occurs when a member will be admitting into the nursing facility from either the hospital or from the community. And then they would like to, or they say that they would like to transition back into the community. Then a rapid referral is when the member is interested in returning back to the community and is experiencing either unstable housing or might have other barriers, complex health issues that would need support of a transition coordination agency. This is when the case manager would send a referral to the transition coordination agency. Next slide, please. Now, the purpose of rapid reintegration is to expedite the process in assisting the members that are admitting into a nursing facility in hopes that they can transition within that 30 days or less time frame. So we are trying to make sure if a member is interested in catching them prior to admitting into the nursing facility and starting the process of transitioning back into the community sooner than later than what's going on or what is currently being done. Next, thank you. So this is just kind of a flow chart to see what the process looks like. This is the case manager would go ahead, and when they're completing the level of care, they would ask the member if they're interested in transitioning or moving back into the community. If the member indicates that they are interested in moving back to the community, this is when the case manager would go ahead and complete the rapid reintegration barrier questions. If they are not interested, then this is when the case manager would just document why they're not interested. And then later on, they would be seen 6 months later after they admit into the nursing facility with either group or individual InReach. Next slide, please. So after they actually end up saying if they're interested in those rapid reintegration barrier questions are done. This is what we'll go ahead and the case manager will complete. If they're if they're appropriate and they have high barriers, then they will go ahead and make sure, the case manager will make sure that they go ahead and send a referral to the transition coordination agency within 2 days, 2 business days after the member has been admitted into the nursing facility. The transition coordination agency will then continue with their current process and procedure when they do receive that referral. So they will be responsible for the rapid reintegration plan and coordination until the member's community transition is complete. The case manager then also will be notified that the community transition is complete. And then if the member, if it is, then that's when they will go ahead and do a post rapid reintegration questionnaire at the end that you can see at the bottom there. Now, if the member has low barriers on the right-hand side, then the case manager will keep the case and assist with the transitioning back into the community. So if they don't have like any housing issues, if it's something the case manager can go ahead and handle, these are all different types of cases that they would not be sending in a rapid referral to the transition coordination agency. So now you can go ahead to the next one. That was just the process. I'm going to open it up to see if you guys have any thoughts, ideas, if you have any questions about the workflow, anything that comes to mind, you can go ahead, put in the chat, or if you want to go ahead and ask it, you can. If you think of anything that comes up later, you can always reach out to me. My email is on here, so you can always keep that, since I will be heading the rapid reintegration process and program and kind of setting forth with it. So if anything else comes up, let me know. Any questions? Clear as mud. Otherwise, I'm actually going to go ahead and turn it over to Sammy.
Thank you so much, Sarah. Hi, everyone. My name is Sammy, and I am also one of the InReach coordinators, and we are just going to do a brief overview of individual InReach. We've gone over this program before in TSAC's meetings, so this might be just an overview for some, and then we've added some additional information just to let you guys know the progress we've made with this. But please feel free to write down any questions that you have or enter them into the chat, and we can definitely go over them at the end during our open discussion portion. Next slide, please. So we are going to go ahead and talk about the purpose. The department overall wants to improve our process to provide a proper procedure to inform residents about their rights to transition back into the community if they wish to reside in the community. This program is meant to complement the work of Group InReach. If we compare both group and individual InReach, Group InReach is designed for any SNF resident to attend regardless of Medicaid status, while individual InReach is only for Medicaid residents to allow for more in-depth conversation with them. One major difference between the two is that Group InReach goes over HCBS, LTSS, and transition services only. The information provided in group is very general to the audience, while individual InReach is more specific and tailored to the individual's unique situation. Individual InReach is a person-centered conversation that will try to answer the members' questions about their own unique situation. During individual InReach, the member will receive options counseling, which allows them to make informed decisions regarding whether they want to transition into the community or stay at the skilled nursing facility. You will notice that individual InReach is very similar to options counseling. The main difference is that there will be some required routine individual InReaches completed along with the new referrals. Next slide, please. Now let's talk about the process. There will be 2 phases overall, the initial phase and then the secondary phase. The individual InReach will have specific guidelines during this initial implementation phase to ensure that every Medicaid member who resides in a skilled nursing facility receives individual InReach. Every member will then be given the opportunity to either receive it or opt out if they wish. We are anticipating a March 2025 start date where options counselors will start completing individual in-reach with Medicaid members. Currently, we have not confirmed the time frame that will be given to reach every Medicaid member, but we will communicate that once it has been determined. After that initial phase, individual in-reach will only be completed for every new referral and for those who continuously opt in currently at the skilled nursing facilities. Members will receive individual in-reach if they continuously opt in approximately every 6 months until they decide to opt out. Next slide, please. And then here is a quick roadmap to go over the process. If we look at the top middle of the slide, we will see that every Medicaid SNF resident, along with new referrals, will receive individual in-reach. So this is during the initial phase, and then after the initial phase, it'll only be for new referrals and anyone who is continuously opting in. If we look at the second row, you will see that members will be given 3 options. Option 1 is yes on the left, that they would like to start the process of transitioning into the community. And then the second option in the middle is maybe. Maybe they would like more information, maybe they want to wait and talk it over with their loved ones, or maybe they would like to see if their condition changes. So if they have a surgery coming up or they're currently in rehab, etc. Then the third option on the right is no. No, they would not want to start the transition process into the community, and they want to stay at the skilled nursing facility. Now let's look back at the yes answer on the far left. If the member decides that they would like to start the process, then a referral will be sent to the options counselor, the options counselor will send a referral to TCA. If the member decides to wait before they make a response and they're in the maybe section, then the member will go back into the queue to receive individual in-reach in approximately 6 months or sooner if requested by that individual. Then if the member states that they are not interested, then option counselors will opt them out. For everyone who opts out, the department's escalation team will follow up with them to verify that they did indeed want to opt out. Next slide, please. Referrals, we'll go over this pretty briefly. There will be several ways that option counselors will receive referrals for individual in-reach. One referral source will be someone who receives group in-reach and would like more information, then they can get referred to individual in-reach. Other referral sources will be if someone states that they are interested in transitioning back into the community following their continued stay review with their case manager during the MDS screen or the PASSAR level 2. Then the member always has the right to choose individual in-reach, and they can actually initiate a referral themselves at any time as well. Next slide, please. So timelines and rates. Individual in-reach must take place within 10 business days after any new referral is received. After the individual in-reach with the members, a referral to a TCA should be made within 2 business days if they decide to opt in. The TCA will follow their current guidelines and will need to engage with the members within 10 days. With rates, our team is still ironing out the details, so we don't have specific numbers to share right now, but we did want to just highlight some of the things that we're working on to cover different pay structures, such as adding a rural pay differential to help compensate for any travel expenses, especially if you're traveling to neighboring regions to help cover some of those referrals. We want to make sure that you're compensated for that travel. Then there will be certain pay rates for in-person visits and separate ones for virtual ones. Then we are expecting that some members will opt out during this initial phase if they're no longer interested. So we are working on different deliverables that can be completed to offset that decline in referrals. This is one area where we would love your input. If you have ideas on what projects that can be deliverables that would benefit the work that you do. Next slide, please. So now we're at everyone's favorite section, the open discussion. This project highly impacts the work that you do, so we value your input since you are on the front lines. Right now, we are curious about your thoughts to this work and are open to any suggestions to make this a smoother process for you. We would also be interested to hear your questions as well. Like I said, this program is still in the developmental phase, so we don't have all the answers, but we will try to find them. So feel free to come off mute to ask any questions or pop them into the chat.
Hello, this is Delane Dunning and I'm Prowers County Public Health. My question to you is, why is this an important issue now when they go into the nursing home every 3 months, the nursing home staff, there are questions to that when they do their quarterly updates for Medicare. They ask the question about leaving or if they want to be there or not to be there. So why is this coming in on top of that already being done?
Thank you, Delane, for your question. And then Chanel, I'm actually going to pop it over to you to see if you have an answer for that.
No, yeah. So Zelene, right now there's kind of a lag time in the process from when those conversations are being had with the member, and when those options counseling referrals are actually getting to you all to be able to go and engage that member. And we're mostly talking about like when it's put in the MDS or if some of the nursing facilities are actually going and actually doing referrals through the Google document that we have right now. And so really what the department is looking at is how can we have continuous presence in those facilities and ensuring that every individual who is entering a nursing facility has this information to back up any kind of decision that they're making, whether that decision is that they really are happy to be in the nursing facility and that is their space and that is where they are best supported, or if the community is going to be a location that they feel like they want to be in and they can be best supported there. So really the goal is really to share that information so that members can make an informed decision. One of the other factors that comes into play is that there is not a requirement for the nursing facilities to actually follow up with the referral. From our understanding, it is a suggestion once they're doing those check-ins with the member that if a member is interested, that they should do a referral, but that doesn't always happen. Like you guys know, just because of turnover or re-education or different things like that. So we're just looking at different touch points that we can help with as a department and with your all support to kind of get that information into the nursing facilities on a more consistent basis. I hope that answered your question.
Well, it does answer my question, but I think it's a duplication of services. The nursing homes already do that. For us, if they want to leave and they want to transfer out, they call us and we transfer them to facilities that they want, or we call the CCT so that they can go into an apartment on their own. And so I think it's already being done, and it just seems to me like it's duplication for us to have to go do it again.
Thank you for that feedback. And I like Samantha said, or Sammy said, we are just kind of looking at this process and wanting to hear your feedback and wanting to see kind of, like you said, where are those things that maybe we can cut back on because they are duplication. And I also want to don't know if that is the same consistent thing across the state. So that's another part of it is we want to make sure that there is some continuity across the state. And if we are able to put this into the contract or into rule or expectations, then we're more likely to have kind of a consistency in all the regions. So that's another portion of it, but I will let Sammy jot that down as a note and we'll keep talking through it. Thank you.
Thank you, Chanel. And then any other thoughts or questions? All right, I'm not hearing any.
Hey, Sammy, there's a question in the chat, and the question is, who will perform the individual in-reach work? Existing options counseling agencies, someone else, and will this be standalone contract versus an amendment to existing contracts?
Thank you, Andrea. I did not see that. So this will be performed by options counselor to replace the current options counseling guidelines. And then for the contract, I don't want to misspeak. So Chanel, can you clarify that one?
Yeah, so this would actually be an amendment to the current options counseling contracts. And I think we've had continued conversation about how options counseling will be transitioning or no longer be available. And so these are one of the projects that we're looking at to hopefully replace that options counseling portion. And so as Sammy was saying, the timeline is still something that we're working on, especially since the current contract is in place. But those are some of the things that we will continue to kind of work through and ask for feedback around.
So this is Shannon with NWCCI. And I guess my other question is right, because right now we don't have an options counselor. And we're still doing transitions. But when this gets in place, if I'm receiving direct referrals from the family or from the nursing facility, then are you setting it up then where I would have to then turn around and refer back to you guys and wait for someone on the Front Range to come to an options counseling before I could continue transitioning?
So no, not right now. I think the process will be very similar to how it is now. So we are looking at trying to extend those options counseling contracts to those regions that do not have them currently, whether that be with a current ADRC or if we have to look at other organizations outside of ADRCs to support that work. But the plan will kind of continue to be the same. If there is not an options counseling agency in that area, I believe the current process is that it comes to Nora and then Nora supports getting it to a transition coordination agency in that region. So it would probably stay the same in those situations, but our hope is that we can get all of the regions covered to take on this individual in-reach work.
Okay, that makes sense. We're the only transition agency, so that's not a big deal. I was just curious as to what kind of flow, if there would be an additional flow of paperwork once this gets started, or if it's going to remain streamlined.
Yeah, I don't foresee that being a concern as far as like the transition coordination referrals. It'll be very similar in process. I think the biggest transition is going to be that it's not going to be just referral based as far as individual in-reach is concerned. There will be kind of an expectation that there is a continuous touch point with each member that hasn't opted out. So I think I foresee there being an increase in transition coordination referrals because those conversations are happening continuously. That information is being shared more widely with members in the nursing facilities. And we're not relying only on the nursing facility staff to get those referrals taken care of, which, I mean, like I said, in some regions, it's happening great. They're doing an awesome job. And then there are other regions where maybe they don't have the education or they have high turnover. So there is a little bit of a lapse. So we're just looking at how we can continue to have that touch point ongoing.
Okay, thank you. I have one last question. So if someone does not opt out, and every 6 months they're wanting to move back into the community, and the transition is not feasible, there just aren't supports and services, is every 6 months we're just going to continue to go through the process, or at what point is someone else to say this is not a feasible process?
No, that's a great question, Shannon. We are actually looking at having our escalation for HCBS kind of help support those things. And so that's information that we want to know. If a member is not able to transition because a service is not available in the region or something like that, that's something that we kind of want to have some data on so we can start supporting that region in trying to get that resource and have it available for that member. but we'd love to kind of hear what your all thoughts are on what that process should look like, because you, like Sammy said, you guys are on the ground, you guys are the ones who are here doing the work, and you know what those daily examples are going to be. And to kind of help guide us through some of those things that we need to be thinking about processes and procedure around. So I think that's a good point, and we will definitely take that back to kind of think through a little bit. And like Sammy said, we're open to suggestions if you guys have any ideas on those things.
There's one more question in the chat, and that is, how will the current OC work wind down or transition?
That is a good question. So right now, we're having conversations about when this is going to start. And so our thoughts are that there will be an overlap between individual inReach and options counseling. And we'll kind of have those discussions more one-on-one with options counseling agencies on like, what does that look like? How can we support you all revving up for this kind of work, because it's going to be an influx of work. As Sammy said, also, what kind of deliverables can we add to the contract so there is a consistent amount of money coming in for the contract, and it's not just all based on contact with those members, because that will have an influx. So those are all kind of things that we would love to kind of sit down and have conversations with you all about. And what makes the most sense and what's going to be the most beneficial for everyone, including the members in your organizations. And it looks like we have a question from Megan.
Quick question. I had a little bit of noise in the background, so I just wanted to clarify. As a case manager, our role in this would be going to complete the functional assessment, and whether the member wants to go through the transition process or not, is it up to us to check back in with them in the 6 months, or what's kind of our, no? Okay.
Megan, are you a case manager at the CMA or?
Yes.
Okay, so I think at that point, because you're a CMA and ADRC, are you all doing options counseling?
We're not doing options counseling, no.
Okay, so yeah, the individual inReach, which I'm thinking that's what we're talking about, will be more for agencies that are providing options counseling right now. Okay. And so they would be the agencies supporting those conversations every 6 months.
Okay, thank you for that clarification.
Yeah, and if you were talking about Rapid, which was what Sarah talked about a little bit earlier, those, like you said, that would be the case management team. They would be, it would be in the CCM, it would be an additional assessment with a few questions that you would talk to the member about and get kind of their feedback on what they think their barriers are, how can we help mitigate those barriers, and this would all be done kind of in those first 30 days of transition to a nursing facility. And so that's kind of what that process would look like.
Okay, so it would just be like another assessment tool, basically?
Yeah, that's kind of what we're looking at right now. Just another level of reporting for them.
Okay. All right, thank you.
Now there's one more question in the chat, and that's from Nicole, and it says, can you please tell me how the OC will know the name and location of each Medicaid resident who needs to receive individual inReach?
Yes, of course, Nicole. So we've had this conversation a long time ago. We are still looking at having options counseling agencies that are functioning or doing individual inReach having access to CCM. So we'll have more details on that as we're moving forward. But our goal is to have all of these built into the CCM system and options counseling agencies having access to that. So that's kind of how you would know. It'd be very similar to case management right now, where we would let you know these are all the individuals in the skilled nursing facility that have Medicaid. And then as an agency, you can determine how you want to sparse out those individuals, whether that be by nursing facility, number of caseload, that kind of information. But that's kind of what the plan is now. You would have access to CCM, so then you would be able to see information about who is there, what kind of are their diagnoses and needs. So then you can really have that direct conversation with that individual and support what their concerns might be. And I know this is something that options counseling agencies have been asking for a while, is access to CCM. So we're really trying to get that in place so that you all can support the work that you need to do more efficiently.
Thank you. Oh,
Go ahead.
I was just going to say thank you for that question. And then any other questions before we transition to the next slide?
Hi, this is Mary with the Center for People with Disabilities. I was just wondering about group inreach, just because we got a memo, I think back in June, that group inreach was supposed to start being performed beginning July 1st by ADRCs and options counselors on a biannual basis to nursing facilities. So I was just wondering what the status is on that.
So we have had conversations with all of the options counseling agencies. We actually had a hang up on our contract. So it is in clearance right now with hopes that it'll be out of clearance and ready for them to sign to get started with that work this month. And so we've kind of had side conversations about group inreach and kind of what it's going to look like. And they've reviewed the contracts. We just are waiting for that signature portion. So it's still coming, Mary. It will still happen.
Thanks.
Thank you, Mary. Anyone else? Awesome. I'm not hearing anyone else, and I don't see anything in the chat. So next slide, please, Chanel. So we've had really good discussion over individual inreach and then also rapid and group. So we just wanted to let you guys know that we will actually have another stakeholder engagement opportunity for you guys. And this will be an informal setting, just so we can talk through some things, answer additional questions that you have or additional items for feedback. And we will actually be going over both individual inreach and presumptive eligibility, because I know we're excited about that program too. So please feel free to register for that opportunity. That will be Wednesday, August 7th at 11 a.m. And then we will put the Zoom link in the chat just so you guys have it. So feel free to join us if you can. And then next slide, please. So thank you again, and here's my contact information along with Chanel. So feel free to reach out if you guys have any questions. And then I'm actually going to send it over to Victoria to talk a little bit about at-risk diversion.
Hi, my name is Victoria Lewis. I'm an inreach coordinator. What I'm going to go over today with you all is at-risk diversion. So we'll go over the purpose and goal of at-risk members and how they're assigned. We're going to go over as well outreach and referrals to targeted case management transition coordination for diversion services. Next slide, please. So at-risk diversion is another new project that the inreach team is working on currently. It is an initiative to advance home and community-based services to proactively support members that are in the community to help them remain in the community. Like the other two projects that we discussed today, we're going to have specific requirements and guidelines, and there's going to be more information and details to come in the next few months regarding this project. We currently do not have a definite date of when this project will roll out. I'm just going to provide like a broad overview of at-risk diversion today. So the definition of at-risk diversion is a person-centered process that provides Medicaid members that are at risk of institutionalization with supports and services to remain in the community setting of their choice. The goal of this project is to provide those at-risk members with additional supports and services so they can remain in the community and avoid admission into an institution or an institutional-like setting. Next slide, please. So every Medicaid member that is identified by the department as at risk will have a case manager from the case management agency or a care coordinator from the regional accountable entity, so Health First Colorado's Medicaid program, assigned to them. So these at-risk members will be divided into two categories. The first one, it's going to be members that are currently receiving HCBS services. They'll be referred to the case management agency for a case manager follow-up. And then the second one is going to be members that do not receive HCBS services. Those members are going to be referred to a Ray Care coordinator. So if the member is not assigned to a care coordinator, then they will make outreach attempts to contact the member for follow-up, and then they'll offer those care coordination services. So one thing just to keep in mind is there is criteria right now being determined, or we're working on the criteria right now to determine like who is at risk for institutionalization, and we're working on that list right now. So it's still being actively, it's in the works, so I don't have like the information to share today about, you know, that criteria to determine who those individuals will be. Next slide, please. And so we'll go over outreach and referrals. So once the member is assigned to either a CMA or Ray, the CMA or Ray will be required to make outreach to these individuals within a specified time frame, Based on the member's needs and preferences and the availability of community-based services, the CMA or Ray will assess for any additional needs, resources, supports, and services to make referrals to other agencies as needed. For members who have been identified as needing like some housing support or additional support through major life events, the CMA or Ray will have the capability to make referrals to transition coordination for diversion services. So there's not going to be a duplication of services. So if the support falls under, for example, the Ray scope of work, and it's something that they can help with, then they will not refer to transition coordination. I'm going to give you some examples. For example, the Ray can assist the member. Let's say the member has complex health needs and they need help finding a medical provider to address those complex needs. The Ray can also assist with like scheduling. They can help collaborate with the healthcare providers to ensure that those members' needs are being met. So like in a case like that, they wouldn't need to make a referral. But another example, like let's say the member is identified as at risk and is in need of housing support or assistance with finding housing, the Ray can only help usually members with like sending a list of community housing resources. They don't have access to housing navigation services to obtain like a voucher or the capability to assist the member to locate housing. So in that circumstance, the Ray will submit a referral to transition coordination because it doesn't fall under their scope of work. Sorry. Once the referral is sent to transition coordination and it's been accepted, there will not be any additional requirements or changes for transition coordinators regarding this project. So every TCA will follow all current processes that are in place now. Next slide, please. So there will be more information and details to come in the next few months regarding this project, as well as how the referral process will look and timelines. we wanted to just share this information with you now. It is a very broad overview. We also want to get some feedback, since this project will impact the work that you do by increasing those numbers of, like Chanel talked about earlier, it's going to increase numbers that we believe, like of those referrals that are coming towards transition coordination. And here's my email address. You guys can send questions or comments directly to me or to the group email address. But I would like to open it up for questions, comments, feedback that I can answer. Nothing?
Hi, this is Mary Jo. I can't find the raise hand part, but anyway, I'm just going to speak up. So, kind of in an overall impression, it appears that as transition agencies, we have been asked to use the ray in circumstances where we can use the ray. And so, and in our cases, we've had pretty rare occasions in which we've used the ray. And I think partly because we don't absolutely completely understand how it would differ from the services that we provide. But it sounds like this is another avenue for us to work with the ray, meaning that the ray is going to refer to us instead of us getting a referral and then trying to bring them in. And I think given the structure, given the place that we receive referrals from, this makes a lot of sense that this referral is coming kind of from a different channel.
Yeah, so basically what it is we're working with our data team right now to develop a model where we're going to identify, it's going to be a certain amount of people, so it's not going to be everybody, but it's going to be a list statewide, who are the people at highest risk for institutionalization. So once we get that list, we will distribute it depending, if they have HCBS, they'll go to, well, they probably already have a case manager, so we'll let the case manager know. But if they do not have HCBS, then we will let the RAY know that they need to outreach these people. Once they make the outreach, they're going to offer whatever supports and services that they need. Rays are going to offer, whatever they're capable of offering, because we don't want a duplication of services, like I said a while ago. But some of the things that transition services is really going to be able to help with, and we're going to narrow down the criteria for it, is going to be that housing support.
Yeah.
Because a lot of times they don't have like the feet on the ground, or all they have is resource lists or homeless shelter lists or things like that. So that is like a big, probably where you're going to I would assume, I don't know for sure yet, probably see most of the referrals coming from is that population.
Yeah. Okay, great. Okay, that helps to know that you'll be identifying them. They have a case manager. You'll be referring them over to the case manager. If they don't, you refer them to the RAY, and then the RAY can reach out to us. Can the case manager reach out to us as well?
Yes. So what's going to happen is we're working with Nora, but we're going to create some type of referral process on how we're going to do this. That way we're making sure that we're keeping track of who's being referred and, who they're being referred to. So that, so all that information will probably be coming in the next few months. And like I said, we don't have like a rollout date yet set of when this is going to happen. We'll just keep having these meetings. We'll keep having these discussions. And then we will also let you guys know on what that referral process is going to look like. And it'll be coming from both RAYs and CMAs.
Yeah, thank you so much.
You're welcome.
Clarification.
Any other questions?
Hello, this is Delane again at Prowers County, and we're in the very southeast corner of the state for Array. And my understanding is the Array regions have not really been set yet. Is that correct?
To my understanding, they have not, but they are going to be changing soon. I believe that they've identified, it's gonna be reduced down to 4 regions to 4 different rays. I think it's kind of being split like, in a 4 across the state. I don't know the lines, but I believe they're working on that. I know they're working on the new ACC contract, so that should I believe they picked them around now or by next month. And so that information, I'm guessing it will be distributed or like available online by next year or early next year, I would assume.
How will we find out when that is completed and we get our region?
We could probably update you on this meeting once we find out more. I know that they're still working through picking who they're gonna pick for those 4 rays, and then I believe they have to go through like some negotiations, and then they'll post it. But yeah, we can definitely update you once we find out more information or like some more like definite dates or when this is gonna roll out.
Thank you. I'd
You're welcome.
appreciate that if you guys let us know. Thank you.
Yeah, we'll make a note of it.
Victoria, this is Mary Jo again. I need to be giving this information to my team, so I just want to be clear. You're going to be identifying people who are at risk for being institutionalized. And so are there particular waivers that they are currently on? Would we be helping them get on waivers? Are they all Medicaid individuals? What are the other categories of the people that you're looking at?
Oh, what I do know is we're looking at those, we're looking at different variables, what makes them at risk. So they're going to be people that are not on. So let's say, for example, somebody is not on a waiver, we refer them to Ray. The care coordinator reaches out to them, and then one of the things that they're supposed to be doing.
Oh, your voice was cutting out. I don't know. That's true for anyone else.
Yeah, I can't hear her either.
Okay. We can't hear. If you're talking, we can't hear. You're muted.
Okay. Can you hear me now?
Yes.
Okay, I took it off
So
camera. Sorry.
You dropped off. Start over, please.
So basically what's going to happen is if somebody is not on a waiver and the Ray reaches out to them, they will be referring those people to HCBS if that's a need for them.
Okay.
If that makes sense. Yeah. And so really what they're going to be referring to transition coordination, like I said, a majority of it would be if they have unstable housing or they need housing assistance. It would have to be something that they're not capable of doing themselves. I know that even like a lot of the Rays, some of them have like peer support. So those peer support people can help them, like, they go and help them fill out applications, or they can help them, figure out like a bus schedule and scheduling appointments and things like that. Those things will continue. It would just be something that they're not able to help with. If that makes sense.
That's great. That's great. And the in our transition work, we do an initial assessment of them, and helping them with housing is kind of our second phase. So would we be looking at doing an assessment for living in the community, or would that already be done?
You would receive that information. So if that is a need, we're looking at putting that in the referral process.
Okay.
We still don't have all the details on how that's going to look, but if you have suggestions, I think it'd be great, to hear different ideas, and, anybody has any like feedback or, suggestions, like I said, on a better process or just anything just to improve this project, we are glad to take that information.
So I might go ahead and just outline that. And would I send that to you, Victoria?
Yes, ma'am.
Just to say that TCA agencies, the assessment is a real critical piece. And it results in whether it's recommended. Of course, we talk to the whole care team, but whoever's working with them, but it's a critical piece of the process because we either recommend or not recommend housing. So I can imagine that these individuals probably come from all sorts of situations. So I know that, and perhaps I'll just let you know what our process around the assessment, and then you can just take that into account.
Yeah.
Yeah.
So what I do know is that Rays, let's say they get assigned a member, they make that outreach and they offer care coordination to this individual. They actually do an assessment themselves.
Great.
And it will go over pretty much everything. And so they'll be able to narrow down and identify the needs of this individual. And then we can, I would love your feedback in regards to once we start coming up with that referral process on what information would benefit transition coordination agencies the most, or you know what I mean? What's going to make it easier for you, or what, what is not a good idea. So we could definitely dive deeper into those things.
Yes. Yes. And we would hope that or I would feel like once the referral came in for housing, that as TCAs, we're really close to all that, the whole process, and we can make that happen. We can work on that. We have a client right now that, we had to go right into the housing piece with this person. And, we do know the details, and we do know how to move that. So hopefully that will be a benefit to the Rays once they recognize they need our help.
Yeah, and I assume we're going to keep having these meetings and keep getting updates. And would it be beneficial, do you think, to have maybe some type a Google form or a survey, something to be distributed so you guys can provide that feedback?
Yes.
Yeah. Yeah.
Okay.
And I think it's the more information you give us and where you are in the process allows us to come up with the feedback.
Yeah, and I think it's great since rapid reintegration also is going to increase referrals, I assume. So we could probably include all the projects, or we can do separate ones for each one, but we'll definitely discuss it as a team and let everybody know.
And I'm sorry, I got one more thing.
Yes, ma'am.
There are a couple of TCAs on the advisory council. I believe LaShawn, I don't know if you're here. There's a couple of us. I'm not on it, but there's a couple of TCAs on the advisory council. So if something needs to be, I don't know, there needs to be a liaison or something like that. We can talk about that.
Oh, that's great. Thank you.
Yeah. Thank you, Victoria.
Oh, you're welcome. Any other questions? Okay.
All right. So, I'd like to thank Sarah and Sammy and Victoria for presenting today. Just a reminder for the next TSAC meeting, it'll be Thursday, September 5th from 2:30 to 4:30. We are still working on putting an agenda together for that next meeting. So we'd like to open it up to this group. If there's any topics that you're interested in learning more about or discussions, feel free to add it to the chat. You can come off mute. If you have an idea of something that you'd like us to discuss in the next meeting, that would be great. Anybody have any ideas?
I was gonna say I wanted to just circle back around, and maybe we can add the raise in ACC phase 3 kind of to that. I don't know if anybody wants to thumbs up if that's something that you all are interested in learning more about. Like, what are the rays supposed to do? How do we engage them? Things like that. We can definitely have somebody from that team and come and do a discussion.
So, I don't know if next month would be too early, just because they're still working on phase 3 and, there's still going to be changes to come. I think they could probably just give information of like what their roles are now would be good. But I just want everybody to keep in mind that ACC phase 3 is not expected to roll out until, I can't remember the exact date, but it's around this time in 2025.
Sounds perfect. If nobody has any questions or thoughts, I'd like to thank everyone for coming today. If you do have any questions or ideas of stuff that you'd like more information on, or have an idea for an agenda, feel free to reach out to me or my InReach team, and we can get back to you. And I'd like to thank everyone for coming today. If you have any questions, feel free to reach out to us. Hope everyone has a great day.
Thank you.
Bye, everyone.